So Dr. Campbell, he also does part-time with Care South and over at Lolly Kemp, Infectious Disease. So we want to bring him up. We want to talk about advances in like HIV treatment and detection, prognosis, prep for our younger individuals, and just our overall state of STDs. So I'll start. So when I looked everything up and was looking over stuff, I saw that I believe it was about black males were 9 times more likely. I'm sorry, not 9. I'm sorry, 7 times more likely to be diagnosed with HIV, and women were like 8 times more likely to be diagnosed, and men were 6 times more likely to die from HIV/AIDS. So again, what we've been hitting on all day is early detection, screening. So what's your take on those numbers?
Well, I would agree with you. Early detection plays a major role. And part of that issue certainly lies with the patient. When you see a provider, you know, getting tested is very important. But another component of that is some providers are quite hesitant to even delve into the issue of whether or not the person they're seeing is HIV infected or HIV positive. And sometimes through miscommunication, patients assume that they've had all this blood work and an HIV test was included amongst those tests. And that's usually not the case. So it becomes incumbent upon the patient, when you see your provider, ask for the HIV test. There are no signs or symptoms for HIV infection. A person can be infected with HIV and have a normal life for the next 8, 10, 12 years. During that time period, that person, however, is contagious or can pass the virus on. The virus is passed on usually sexually, or if they're doing IV drugs, through sharing needles. Again, the person that's infected will appear normal. They're not losing weight. In fact, they may be obese. They're not having any problems. And then as their T cell count drops, and the question becomes, well, what is a T cell? A T cell, if we can just imagine that our bodies are castles or fortress.
Dr. Campbell, I think we got to bring it up a little bit.
T cell is is a guard that protects that castle. And so you can imagine guards walking around the castle with shields and spears, guns. The virus attacks this castle. HIV attacks, and it keeps attacking over and over through years. The problem is that the guards are lost. They're destroyed. They die, but they're not replaced. And once the number of guards gets down to 200, that's AIDS. That's a very significant loss to the immune system. And it's at that point that that person who's been infected for 8 or 10 years becomes symptomatic, goes in for medical care, and then at that point gets diagnosed. And so the best approach would be, when you go for your annual exam or however often you're seeing your provider, at some point, at least once a year, request an HIV test.
And can you speak to the advances in the treatment of HIV now with the injectables?
Right, that's a very good point. There have been very significant advances in treating HIV. Let's back up a little bit real quickly. What is HIV? HIV is a virus. And so by definition, a virus has to infect another cell to continue to replicate. And there's, I don't know, thousands of different viruses. Hepatitis viruses infect liver cells. HIV and for instance, or unfortunately infects CD4 cells. So the HIV virus is geared to infect that particular cell. Viruses that causes colds and pneumonia, they're geared to infect the cells of the upper respiratory system. So HIV is a virus. It has to infect a cell to replicate. And so if we were to take HIV and watch it under an electron microscope on a culture plate here or surface, over about 48, 72 hours, the virus would just dry up and die. Because again, it has to infect the cell, the CD4 cell, in order to replicate. The drugs will go back in time to 1989, 1991. Treatment for HIV at that time required about a person take 12 to 15 pills a day. And a lot of those pills had side effects. We fast forward as time has passed, we're now at a point where a person only has to take 1 pill a day. That 1 pill, though, may have 3 or 4 different medications in the pill. And so they're taking that 1 pill once a day. Unfortunately, though, when people ask me, well, how long do I have to take this medication? I still have to tell them until they find a cure. Well, when is that going to be? Have no idea. So the medications, they suppress the virus, they prevent it from infecting the CD4 cells, disrupt the ability of the virus to replicate. And the medications, the pills, they're very, very effective. They're able to actually eradicate the virus out of the bloodstream. But that's not a cure. The virus is still there in the organs and the bone marrow. There are drugs now that are available where a person, if they do not want to take a pill, they can take an injection. The injection is given once a month or every 2 months. Those drugs are very effective. When I see someone newly diagnosed with HIV, one of the things I make sure that I tell them, they're not going to die from HIV. Why not? Because the medications are that effective. So someone that's, I don't know, 30 years old, living with HIV, I would expect them to live as long as someone without HIV. The lifespan is the same. And so it's very sad. Well, do people still die from HIV? And the answer is yes. Why do they die? They have mental illness, they're addicted to drugs, or they're in self-denial.
I just want to say embarrassment.
They're embarrassed, they're stigmatized. I've had a few people choose keeping their diagnosis hidden and choosing death versus seeking treatment and having their diagnosis revealed.
And at our clinic, I think you and our nurse practitioner, Dr. Bell, you guys have our numbers, and where like 98% are suppressed of our patients that come in on a regular basis. They're getting their injections or taking pills. You know, if they show up for those appointments, it's suppressing that virus, and we have about like a 98% suppression rate.
Right. I want to say the national average is like maybe 88, 90, 92%, but at CareSouth, the patients, they do come in and they take their medications, get the injections, and that's the key thing. Taking the medication, keeping the virus suppressed. And it sounds real easy, 1 pill a day, but 1 pill a day is hard. Imagine you're going to take 1 pill a day for the rest of your life, or at least until they find a cure. And we're now going into like maybe 30, 40 years, and so far there's no cure. However, the injection is an alternative. If a person grows tired of taking the pill every day, the injections are available, assuming that the person, the virus that they have, will be susceptible to the medications in the injection.
In our rates here in Louisiana or even Baton Rouge, New Orleans, how do we compare to the rest of the nation?
Unfortunately, I want to make sure I speak correctly, but I believe it was New Orleans followed by Baton Rouge. That's number 1 or number 2 for chlamydia in the United States. So in this general area being the southeastern United States, the rates for sexually transmitted diseases, in addition to HIV, are very high. There's an increase in syphilis. And unfortunately, with syphilis causes a genital, or wherever the entry point is, into the uninfected person. It'll cause a sore or an ulcer. And a lot of times, some of these infections travel together. So we have a high syphilis rate, or an epidemic really now. Probably in 8-10 years, those patients, some of those patients that had syphilis, they're going to be diagnosed with HIV, and the HIV rates will go up.
Now, we talked earlier before this. There was a thing that was out, I believe it was something like super gonorrhea or something like that, that was being resistant to the medicines that we use.
Right. There is a concern for resistant gonorrhea. And again, the question becomes, well, what is gonorrhea? Gonorrhea is a bacterial infection, usually sexually transmitted. It can infect the urinary genital tract, usually the urethra, the tube inside the urinary tract, and men and women that carries the urine from the bladder to the outside. In women, it can ascend through the genital tract into the fallopian tubes and uterus, and cause pelvic infections, ectopic pregnancies, and cause infertility. Unlike HIV, though, this is a bacteria, and so you can treat this with antibiotics. Recently, there was a concern for gonorrhea, or Neisseria gonorrhea, the formal name for the bacteria, becoming resistant to antibiotics. In response to that, the current dose of the injection has been increased, and there have been some modifications in the treatment. Usually when someone has gonorrhea at a clinic, or they're diagnosed with it at a clinic, or chlamydia, a lot of times you just go ahead and treat the person for chlamydia and gonorrhea. Has there been a outbreak of resistant gonorrhea here in this area? And the answer is no. Several years ago, there was an outbreak over on the west coast, Hawaii, but we haven't seen that here. I want to say maybe sometime last year in 2023 or 2022, there was a report of one case, I believe, in New Orleans.
And one last question on that note, and then I'm going to maybe hepatitis B after this. But so PrEP, right? So I've had, again, what you said earlier with providers not screening for HIV. A lot of providers are reluctant to have that discussion with their patients, especially the younger patients, regarding PrEP. A lot of our, I've had, not a lot, I'm not say a lot, when I probably had maybe like 5 come into my office and ask me directly about PrEP. And if you can explain to what PrEP is, how we use it, but a lot of them were reluctant to start it because their first question was, will this show up on my parents' insurance, right? Well, when they go to pick that medicine up, that claim is going to be on there, and if the parent sees it and they want to go Google that medication, they're going to start calling that child, that's in school. But if you can explain what PrEP means and why we use it.
Well, PrEP is medication that a person can take before they're sexually active with someone that has HIV infection. And this medication will protect them. And that's another reason why it's so sad to see people die from HIV. But the medication will protect them against possible infection from the other person. this medication, PrEP, P-R-E-P, comes in 3 different flavors. Flavor number 1 is Truvada, which basically is an antiretroviral therapy that's taken with other medications to treat HIV. A second drug, which is a pill, is Descovy. Now, the Truvada is effective in men and women. Descovy primarily is just for men at this time. And then there's an injection, a drug called, the trade name escapes me, but cabotegravir, which is an injection once a month, and then it's every 2 months. And that injection will protect a person against HIV infection.
So if you had a child now, I don't know, maybe high school or going to college, they came to you and they told you they were sexually active, are you saying, hey, with daughters, you'll say, hey, you're going to get on birth control pills? With your sons, are you going to say, hey, let's start this PrEP treatment?
The rates for HIV and sexually transmitted diseases in this area, again, the southeastern United States, are just really off the chart. And part of the reason it's off the chart is that a lot of these infections are asymptomatic. In other words, a person can have gonorrhea, a person can have chlamydia, but they will not have any symptoms. When I was younger and crazy in the Navy, if a person had gonorrhea, you didn't have to go and find them. They were running to the doctor, male or female, because it was like they were on fire when they would urinate. Fast forward to 2024, no symptoms. Whether the infection is in the urinary tract or in the anal system, there are no symptoms. And so when the person becomes sexually active, they can transmit the virus, or the infection rather, to other people. And so the infection rate just continues to go up. The answer to your question, though, which I kind of like circled around, is yes. I would be compelled to advise my son or daughter, my children, and again, that's my own personal opinion, but part of that is driven because what I've seen in the clinics, I would advise them to take PrEP. Now, PrEP, that could be an injection or a pill. Of course, though, the person has to be committed to keeping their appointments, because these drugs are not benign drugs. They do have side effects. And so you have to monitor their kidney function, liver function, and then you want to make sure, test them on a regular basis, document that they're taking the drug and that they are not HIV infected. Because you give a prescription to someone doesn't mean that they're going to take the prescription. So if they're non-compliant with the medication, they can get HIV infection. And so the drugs that are used to prevent HIV infection also are used to treat HIV infection. If they lose one of those drugs, you've just taken away a drug, and why would they lose it? The HIV virus will become resistant to that one drug, because you can't use one drug to treat HIV. But the answer I would give, and again, that's my own personal opinion, would be yes.
Yeah, and so I would echo that, and I would say if the stigma is that their parents are going to see that on that insurance, think that they are HIV positive or having some alternative, lifestyle, and that's what they get afraid of. And so I encourage people, if that was to ever happen, to definitely use that as a conversation piece with your child, because like you said, those medicines they work so well. you know,
They do work.
for your child to end up, you know, HIV positive, when there, you know, when there are things that help to prevent that from happening. The other part that I wanted to talk to you about were the advancements in the treatment of hepatitis C. You know, they were doing those interferon injections in the past, and now we have the pills that we take for a few months, and from my understanding, it's even reversing some of the scarring of the liver as well.
Right, so hepatitis C, again, this is a virus. And so by definition, a virus has to infect other cells to live. This particular virus infects liver cells, the hepatitis C virus. And what's the problem with that? Well, the problem with that is once that virus gets into the cell, the body's immune system sees the virus in the sense of an immunological sense. It sees the virus there. It knows, hey, this virus is not supposed to be there. So the body sends these special white blood cells to that location in the liver to get rid of that virus. In the process of doing that, it creates scar tissue. The other problem is that the immune system cannot totally eradicate it. And why not? Because the virus is on the inside of the liver cell. And so it's hard for the immune system, for the white blood cells to get to it. And so over a period of time, 10, 15, 20 years, again, depending on the individual, the liver gets replaced by scar tissue. The liver is a very wonderful organ. If we were to try and do everything the liver does, we'd have to build a chemical plant at least covering 10 acres because it's always breaking down protein, storing glucose, all types of things. But when you replace that with scar tissue, that liver now is non-functional. It can't do all those magical things. And a human being cannot live without a liver. So treatment, up until about maybe 15, 20 years ago, was using interferon, which is a type of injection, along with another pill. A lot of side effects. Fast forward to 2024, the treatment now is 1 pill a day for 3 days. And these are, I'm sorry, not 3 days, 3 months. 1 pill a day for 3 months total. And what this pill does, it blocks or interferes with the ability of hepatitis C to replicate. And we're not talking about just containing the hepatitis C. We're actually talking about a cure. The hepatitis C is gone. But again now, just like with HIV and some of these other diseases.
Dr. Campbell, we can call it a cure now? I mean, I've never seen anyone treat it and then come back with a viral load, but we can call that treatment a cure?
It is called a cure. So you treat the person for the 3 months. They come in like at week 4, you test their blood, they come back, and I want to say the guidelines say if they are undetectable, in other words, if you can't find the virus in their bloodstream at the 4-month mark, they're considered cured. I usually take them out to 6 months, and if they're negative at 6 months, then I declare that they're cured. They don't come back and see me for hepatitis C. But now keep in mind, unlike hepatitis A and B, when a person gets hepatitis A or B, they become immune to that virus. If they're exposed to it again, they can't get sick. If a person became infected from hepatitis C by using IV drugs, and they go back to that lifestyle, they can get hepatitis C again. And so to achieve that cure requires not only the medication, but the patient changing their lifestyle, avoiding the activities that got them into trouble in the first place.
And so so we hear about IV drugs, but I think what some people forget about are those homemade tattoos that people had back in the day, or the jailhouse tattoos that people have had.
Right.
And that they could have contracted hepatitis C years ago when they got those tattoos under the garage.
Right. I believe the CDC, at least maybe 4 or 5 years ago, said by the time a person is diagnosed with hepatitis C, they've usually had it for about 10 years. And so what are the risk factors for getting hepatitis C? Blood transfusions before 1993, IV drug use, non-professional tattoos, men that have sex with men, that's a risk factor. Having said that, though, people that are heterosexually oriented, hepatitis C is not considered a sexually transmitted disease. But those are the risk factors for hepatitis C infection. In the United States, primarily, it is IV drug use.
Well, I appreciate it. You want to give your wrap up?
The only thing I would add, and I know the hour grows late, the most important thing I can advise anyone is get HIV tested. Your provider, and you say, well, geez, why is my doctor not telling me this? Unfortunately, a lot of doctors, they're not well informed about HIV, and so they associate death with HIV infection. And when you ask somebody to start talking to another human being about something that potentially may result in death, that raises up fears for their own mortality. And so they just won't go there. But the area that we live in, the southeastern United States, El Paso to Miami, you have to make sure you're getting tested regularly on a regular basis. I would say at least once a year. What would cause you to be tested more quickly or more more frequently? If you're sexually active, if you have multiple sexual partners, if you're not in a monogamous relationship, and then some people would say, well, yeah, even in a monogamous relationship.
The person might not.
But the other person, you may be monogamous, and you're right, the other person may not be monogamous. So all those things would cause me to say, well, you need to be tested more than once a year, but at least once a year. And the question comes up, well, I'm not sexually active now, and I don't know, I'm 60, 65 years old. I don't need to be tested. Keep in mind, the infection could have occurred 10, 12 years ago, and your T cell count just hasn't got down to that critical point.
Dr. Campbell, thank you for your information. I'm listening and I'm hearing everything about PrEP, HIV, and everything you covered, but for the like of me, why do the CDC and doctors act as if herpes is not around, except it has a negative stigma, but medical professionals such as yourself, not you, but medical doctors, CDC, they think herpes is like, oh, it's nothing. Everybody has it. They don't even know. It's nothing. I know there's medication for it, but again, it's not undetectable. It doesn't just go away, but it stays. So why is it then everybody treat herpes? It's like, don't worry about it.
Well, I think part of that problem is HIV, syphilis, gonorrhea, chlamydia kind of overshadows herpes. I thank you for pointing that out, though, and bringing that up. But yes, herpes is definitely out there in the community. Question is, well, what is herpes? It's a virus that usually is sexually transmitted or can be transmitted through contact. And the hallmark of herpes, it causes a recurrent ulceration at the location, at the same location.
And painful, as opposed to non-painful.
Pruritic. It may be associated, if it's in the genital area, it may be associated with inguinal lymphadenopathy. There is medication that a person can take to suppress the herpes virus. Keep in mind, though, the herpes virus can be transmitted without any ulceration. A person can have herpes and totally have no ulcerations visible. It's hard to eradicate well, it cannot be eradicated, just as the gentleman pointed out, because the virus lives in the skin or tissue. But you can, individual can take medication that will suppress the virus. And what was some of that medication? Valtrex, Valtrex, or a drug called acyclovir. It will suppress and prevent recurrent ulcerations.
Why is it treated like it's nothing by other professionals?
Well, I think, again, it's overshadowed by the other concerns. And then I think some providers, they just don't know how to deal with it. A lot of providers will make the mistake of ordering blood tests. Someone will come in and say, okay, I have herpes, but they don't have any genital ulcerations. And so the provider will order a blood test. The blood tests are really not that good. The only way you can diagnose the virus is to culture or fluid from the vesicles, little vesicles or blisters that occur when the virus is active. Getting the blood test may tell you what has happened in the past, but it doesn't tell you what's going on now.
And that was going to be my point. I think it's not that the physician doesn't care or ignores it. It's really incumbent upon the patient to let us know what symptoms they're having, because I just don't order that blood test on everyone because of it's not that reliable. Like you said, it tells you what happened in the past. And so what you do is you want that person to come in when they're having an outbreak so you can culture it, you know they have it, and then you can put them on suppression therapy. But most of the time, it's just that the patient isn't telling you about having an outbreak. It's not really in that screening panel, because that test is just not that reliable, and we have to rely on the patient to tell us that, hey, they're having this going on, or I've had this, I don't have it right now, but this is what happened in the past. And you try to get them to come in when they actually have an outbreak. So, because you have to physically try to, culture that lesion, unroof that lesion, and get that fluid and send it in, Correct.
That's why people have it and they don't know they have it. It's not always those situations.
Right. I mean, when we do our STD talk with our patients, we try to differentiate which ones are bacterial and which ones are viral. So we'll also go over genital warts, we'll go over HIV, we'll go over herpes, and then we'll talk about gonorrhea, chlamydia, being bacteria. So we do that in our annual visits, and it's broken up by by ages. And it, has your screening tests, STDs, and we kind of break it up that way and address it during annual visits.
Yes. Thank you.
Thank you.
I want to take time to thank everyone who came out and to support this event. I want to thank all my panelists. Additionally, the sponsors, which is Braille and the mayor's office, and everyone who came out. Thank you so much.
Thank you,
Dr. Garner.
Thank you for putting it on.